Partial rectal prolapse is when only part of the circumference of the large intestine comes out through the anus. Full thickness prolapse, when the whole circumference, all the way round comes out. Actually, full thickness rectal prolapse is far more common than partial, which doesn't quite make sense. And the diagnosis of full thickness rectal prolapse is easier. Partial rectal prolapse actually makes it quite difficult and is easily confused with piles, both by non-specialists and specialists. Actually, the symptoms of rectal prolapse are the sheer prolapse coming out of someone's bottom. Is only occasionally painful, sometimes associated with bleeding, but lots of people have mucus coming out which can excoriate and damage the surrounding skin. In the early days, the prolapse comes out when people go to the toilet, but as things progress, this can come out while walking, and in some people, it's out all the time. As the prolapse progresses, it can weaken the pelvic floor, and that in itself can lead to incontinence. The sheer presence of a prolapse through the bottom means you can't use your bottom muscles to keep the poo in, so incontinence can occur. There is no common cause for rectal prolapse. In women, difficult childbirths can lead to this, but difficult childbirth isn't the only cause, because of course many men, including young men, have full thickness rectal prolapse. There are other things such as hypermobility syndromes. These are where the soft tissues in the body are very stretchable, and this can lead to some people having prolapse. Other people say having long-term constipation can aid this. Having all three may lead to this, but there are also many people who have none of these three things. So overall, you can say that those three things I've described could be a cause, but it could be neither. Surgery is the only way to fix a rectal prolapse. This doesn't mean that everyone needs surgery. That is a judgment call between the patient, the surgeon, and the risks involved. There are 4 main ways to repair a rectal prolapse: two through the bottom, two through the abdomen. The ones through the bottom vary depending if the prolapse is small or large. If it's a small prolapse, we do something called a Delorme's procedure, where the inner lining of the bowel is elevated, cut away, and the underlying muscle is then concertinaed through stitches. If it's a larger prolapse, the operation through the bottom is an operation called an Altmeyer's, where the bowel is actually cut away and then joined together. Through the tummy, there are 2 ways to operate. One, where you operate behind the rectum, the last part of the large intestine. The rectum is then hitched up and stitched up. Or there's another operation where you operate in front of the rectum, behind the vagina, where you'd use mesh, either biological or synthetic, stitch it to both, and then hitch those up. The last one I described is known as a ventral mesh retropexy, and is the only operation where you're reconstructing the body's own anatomy. There are pros and cons of all of these, and we generally defer the operations through the bottom to older people, because 1 in 3 come back, but still it's a good operation. The best operation in terms of success is the ventral mesh rectopexy. In terms of ventral mesh rectopexy, I've got the largest number of operations of this done in the country robotically, and my success rate is equal to the international experts. With regard to mesh complications, this is very controversial, and I discuss this with every patient and let them decide what they want doing and give them all the evidence available. There are unfortunately no non-surgical treatment options. With early prolapses, some patients prefer not to have an operation. This is absolutely acceptable. What we do know is that the longer a prolapse exists, it stretches the pelvic floor, and stretching a pelvic floor can lead to its own problems, such as fecal incontinence. Unfortunately, rectal prolapse cannot go away on its own. Pelvic floor physiotherapy or medicines do not reconstruct the soft tissues which have been damaged, which held the bowel up. They've gone for good. In some people develop a prolapse and it gets no bigger, but the majority tends to increase in time and increase the damage it does to the pelvic floor.